switch gears and talk about the digitization of healthcare, because that I think will have even more profound implications on our healthcare systems. This is a graph of the adoption of electronic health records in American hospitals. And what you see, I can simplify the message here very, very easily. A decade ago, fewer than 1 in 10 American hospitals had an electronic health record. Today, fewer than 1 in 10 does not have an electronic health record. So in the space of less than 10 years, we've gone from an industry whose main way of collecting and storing and moving data around was the piece of paper and the fax machine and the Post-it note and the 3-ring binder, to an industry that is overwhelmingly uses electronic health records in both hospitals and doctors' offices to collect and store and move information around. This is a remarkable transformation in an enormous healthcare system. The U.S. healthcare system is a $3.5 trillion industry. So a trillion is 1,000 billion. So just to give you the scope of the American healthcare system, it would be larger than the economy of most countries in the world. And we have transformed that system to a digital system in a short period of time. How did that happen? Well, the main reason was our federal government in the U.S., starting in about 2010, created an incentive program where they gave dollars to hospitals and to doctors if they implemented an electronic health record, with the threat that if they didn't by 2015, they would begin seeing their payments from the government cut. So there was a short period of time in which you knew that if you put in a computer system, you would get extra money to support the purchase. They didn't pay for the whole thing. It was partial subsidy. And you knew that if you didn't do it by the end, you were actually going to have your payments deducted by the federal government. Our U.S. government pays for about half of healthcare. Half of it is private. So through that incentive, they really succeeded in converting our system from a paper-based system to a digital system. Now, why I got interested in this is I'm not an informatics or information technology expert, but I got interested in this for a few reasons. One is my iPhone, and I think all of us really came to believe that technology was magic. And all of a sudden you had this device in your pocket that could communicate with your parents and take pictures and make restaurant reservations and show you maps of how to get anywhere. It was really remarkable, and it didn't seem to be all that hard. You downloaded an app and off you went. So I think we all got lulled into a false sense that this would be easy and wonderful right out of the box. The second reason that I particularly was interested in computerization is I have spent the better part of the last 15 years studying medical errors and patient safety. And in the days when we wrote our prescriptions on pieces of paper, there were thousands and thousands of errors born of doctors' handwriting. And here's a prescription, and most American doctors would look at that and say that is a prescription for what we call Coumadin or warfarin, the blood thinner, which of course makes sense, except it's not. It's actually a prescription for a medication we call Avandia, Avandia. And if you squint your eyes and have a rich fantasy life, you may be able to see that that could be Avandia. The pharmacist got it wrong and the patient had a very bad outcome. So part of my interest in computerization was recognizing that a lot of medical mistakes happened because of paper records. And then this happened about 4 years ago at UCSF. We had a 16-year-old kid who was supposed to get one of these pills, Septra, you may call it cotrimoxazole or Bactrim or trimethoprim sulfa, a common antibiotic. He was supposed to get one of them twice a day, and we have a fully computerized system. We have what's called the EPIC system, probably the best one, at least in the United States. We have computerized order entry, we have barcoding, we have all the things you're supposed to have. And in a completely computerized environment, we ended up giving this kid 39 pills rather than one. And this is what 39 pills look like, created by the computer, picked out by a robot and shrink wrapped and barcoded. This error began as a simple mix-up between what the doctor thought she was prescribing, a certain amount of milligrams, and the computer was set to milligrams per kilogram. So it multiplied her milligrams by the kid's body weight. But when I heard the error at a conference being discussed, I realized that wasn't really the problem. The problem was that alerts fired after the doctor submitted this order, because of course it's a ridiculous order, 39-fold overdose, and the doctor ignored the alerts. And then an alert fired for the pharmacist, and the pharmacist ignored the alert. And why? Of course, because they get thousands of alerts a day, most of them false positives. And then in the old days, an order for 39 pills would have gone to a pharmacy technician who would have seen it and said, well, this is crazy, I better ask someone. But as I mentioned, it now goes to a robot. And when the robot sees an order for 39 pills, it says in robot language, okay, and it pulls out 39 pills. And then, most interestingly, it went to a young nurse in her first year. She saw an order for 39 pills. She knew this was a crazy dose, but she said to herself, well, I know to get to me, the doctor had to approve it, the pharmacist had to approve it, it had to make it through the robot. They have computers, they have alerts, they have alarms, but I better be sure, so I'm going to check it against my barcode. And she barcodes the first pill, and the barcode machine says, well, I need to see 38 more. Because at that point of the medication process, the job of the barcode, the safety system, is to be sure that the nurse gives the, quote, correct dose. And if the dose is wrong in the computer, then the barcode confirms that dose. So the nurse believed this is the right dose and gave this kid 39 pills. Just by luck, he didn't die, but he had a seizure, spent a week in the intensive care unit. And I suspect he'll never have a urine infection for the rest of his life. It was after seeing this that I said, I have to write a book about this because this is remarkable. The computer was doing some really wonderful things. It certainly was preventing certain kinds of errors, but it was creating new kinds of problems that none of us anticipated. So that's what I want to talk about with you, and then talk about why, even though I wrote this and have been thinking about it because I was disappointed, I actually think we're on the path to something that's going to be pretty wonderful for patients and for doctors. We put it in a little bit of context, at least in American healthcare, and I imagine this may be true in your country as well. To me, American healthcare is in the middle of two enormous trends, enormous changes. The first is that we now have real pressure to deliver what we call high-value care. That's shorthand for care that is higher quality, safer, more accessible, more satisfying, and at a lower cost. 10 years ago, we weren't being measured on it. It wasn't being publicly reported. Now it's happening all sorts of ways. Patients are being surveyed. It's available on the web. Our payments are cut from the government insurers if too many patients get readmitted. All sorts of pressures to deliver high-value care. The second transformational trend to me is the computerization of medicine. If you ask me today, in my job running a very large department of medicine, which one of these is the more important one? Which one do I worry about when I drive to work in the morning? There's no question that it's that. There's no question that our main pressure today is how can we deliver care that is better, safer, less expensive, more satisfying. I may be biased because I live in Silicon Valley and I'm surrounded by Google and Apple and Twitter and Facebook, but I believe in 7 or 8 years it will turn out that the computerization of medicine will have been the bigger change, the more important change. And the reason I say that is I can't think of an industry that, if you look at it 15 years after widespread computerization, widespread digitization, had not been completely transformed. Whether the industry is how you buy a book or how you hail a taxi cab. I don't know if you have Uber there, but Uber is mostly taken over for taxi cabs in the US. Airbnb, how you buy clothes. I was in Philadelphia the other day and tried to find a paper map. I couldn't find one because nobody uses paper maps anymore. The newspaper business, you basically can't find an industry that 15 years after the core information was computerized had not been completely transformed. Kodak out of business, Barnes and Noble bookstore, you name it. So I believe that by 2025, at least in the US, healthcare will be 15 years into widespread digitization, and I think we will see that kind of transformation, although the path is clearly bumpier than any of us thought. So let me talk a little bit about what has been bumpy. Why has it been very different than we expected? It's certainly not as simple as downloading an app on your iPhone. It's been a much, much more interesting and challenging path to computer nirvana than any of us expected. So let me give you a few things. These are things I learned in the process of spending a year doing research for my book on this. This is the first thing that clearly went wrong. A 7-year-old girl several years ago went to visit her pediatrician, and she's an artist, and she came home and drew a crayon drawing of her visit to the doctor. And here it is. You see in the middle of the picture the girl, next to her, her mother and her sister, and there in the corner with his back to the patient is the doctor typing away. How can the girl or her mother believe anything other than this doctor cares more about the computer than cares about me? And I think it's a magnificent drawing. There's only one thing the girl got wrong, which is the smile on the doctor's face. The doctors are very unhappy about this because they don't want to be spending all of their time entering data into computers. And in the US, the fastest growing field in medicine now is a field called scribes, meaning people who are hired to come into the room with the doctor to feed the computer, to type in the computer, so the doctor and the patient can look each other in the eye again, a remarkable thing that none of us would have predicted a few years ago. This is another thing that surprised me. When I was a medical student in Philadelphia a long time ago, the central hub of our hospital was in this room called the chest reading room in the radiology department. And this professor, Wally Miller, was there every day, and every team, the medicine teams, the surgery teams, came down to look at their films. I don't know if you have digital radiology in Brazil. In the US, I have to tell my medical students that those things behind him are films because they've never seen one. They've only seen digital images of x-rays, but that's what we saw. We had films, and we came down to look at our films, and as long as we were there, Wally taught us. So he would ask us what team we were on, and we would say, and he would put his foot on a button, and that machine behind it would spin around until your films came up. And he would say to me as the medical student, tell me the story, and you'd say, this is a 46-year-old woman with a history of lupus who comes in with a fever and shortness of breath and a productive cough. And he'd say, well, what do you think of that x-ray? And I'd say something wrong. And he'd say, no, that's not right. Look, that has to be tuberculosis, or that must be lung cancer. These sessions were wonderful. They were instructive. They were fun. The radiologists learned about frontline medical care from us. We learned about radiology from them. Now, about 17 or 18 years ago, radiology went digital. The reason was that now, rather than getting a chest x-ray or a kidney, a KUB, we were now getting CAT scans and MRIs. And so rather than printing out 2 images, we had to print out 100. And the cost of that was too high. The cost of digital storage went down. And really within a year, radiology went digital long before the rest of healthcare. Everybody anticipated some parts of that it would make reading the films easier and finding old films easier. What they did not anticipate was that those wonderful rounds with Wally Miller would end. And I've gone back to ask people, did anybody even speculate or even raise the possibility that those rounds would end? The answer was no. But within a month, those rounds ended. And the reason, of course, was we no longer had to go to radiology to look at our films because you could see the images anywhere there was a computer. And so the radiologists, I think for a few weeks, were pretty happy with this because they didn't have all of those annoying clinicians coming down to get in their way. And then they started getting really, really lonely because they started wondering where all their colleagues had gone. And now a lot of them are pretty unhappy because they're sitting in a dark room somewhere, just reading one image after another, disconnected from clinical care in a way that was not true 20 years ago. In fact, this gentleman, whose name is Paul Chang, was one of the founders of digital radiology. He's a radiologist and a computer expert in Chicago. And his father is a radiologist, and his father's nickname for his famous son, you'd think his father would be very proud of him since he was one of the inventors of digital radiology. But his father's nickname for him is the man who ruined radiology. Because the radiologists have really been unhappy about losing their connection to frontline clinicians. Well, I think there are some interesting lessons. In the U.S., the term we would say is canary in the coal mine. I don't know if that translates, but things that are lessons that are relevant to us today. The first is that the computerization of the thing, in this case the X-ray, creates the opportunity to make it available infinitely, a perfect copy of it, infinitely available at no cost. Now, it turns out that's not specific to radiology. That, of course, is the economic model for Facebook and Google. That is why the companies are worth hundreds of billions of dollars, because they built something once, made it really good. They can distribute it around the universe at very little extra cost, and they figure out a way of charging you for it every time you use it, largely through advertisement. So that's a clear economic rule for Silicon Valley. But here's what really surprised us, which is that social relationships and communication patterns that depended on us gathering around the thing, in this case the X-ray, will be broken apart. Power relationships mediated by who controls the thing will be renegotiated. I no longer have to ask the radiologist to see my films. I can see them on any computer. And radiologists, I think, have lost some power and prestige because of that. But what's interesting, and the reason I'm talking about this, is all of these lessons are relevant to what happens when the medical record is computerized. And now patients have total access to it because it's now, they don't have to come to the hospital or the doctor's office to get it. Apple is now making available on your iPhone a download of your medical records from many hospitals in the U.S., and I expect in a few years all hospitals will make that available. And companies are building apps to begin working with your medical record. The analogy to the radiology department, in the same way that we don't go down to radiology, I find that my residents spend most of their day in a room with the computers rather than near the patients. In the old days, they were near the patients because that's where the charts were. And so by being on the floor with the charts, they met the family, they talked to the nurses. Now they leave the floor very quickly to go do all their computer work. So these are all, to me at least, unanticipated consequences. I didn't guess that it would happen, but I think now we've become much smarter about it. The final unanticipated consequence, I think, is shown here. This is an advertisement I found for an emergency medicine doctor job in our state of Arizona. And it begins by saying that there's a new hospital coming to Arizona. It's a pretty small, what they call boutique, sort of nice, fancy, but relatively small hospital. And then the advertisement starts, and these are the things, remember, they're trying to recruit an emergency medicine physician. So the first thing they say is we have an emergency room, which is good. They have a radiology suite with some of the latest technologies, 2 state-of-the-art operating rooms. It's a little tiny hospital, 16 inpatient rooms. But the only part of the advertisement that they put in bold, they clearly thought it was one of their main attractions, was that they have no electronic medical record. So this is a modern hospital advertising for a doctor saying you can come here and still write on pieces of paper. That was really one of the signs where I realized that this was not going as well as any of us hoped. And in fact, in the United States, rates of physician burnout have gone up considerably. And when you ask doctors why, they point to the electronic health record as either the first or the second most important reason, largely because of that picture of the amount of time they're spending entering data into it. So let me spend a few minutes giving you some of the things I've learned along the way that I think are relevant to you and your medical system, and also point the way toward what I think will be a more hopeful future. The first lesson is that we are very early in this. Here to me is the 4 stages of information technology in healthcare. The first is you have to take the record and make it digital, no longer store it on pieces of paper in charts. The second is you have to figure out how to connect all the digital pieces so that the hospital system connects to the GP system. Your Fitbit, if you have that, or whatever, your Apple Watch, or whatever monitors your digital scale connects to the hospital system, to the GP system. All of these things connect up, so there's really one digital flow of data as there is in the financial system, for example. I can put my Bank of America card in the Citibank machine, and it knows who I am, and it gives me money. So that's the second stage. All of the different digital parts all connect. The third is we now take all of this digital data in our system and we glean meaningful insights from it. We analyze the data using methods that some of which are relatively new, some are not new. We analyze the data to help us predict things better, or try to figure out what is the best way to treat this patient or patients like this. The fourth is the hardest, which is we take all of these insights and we convert them into actions that improve quality, safety, patient experience, or lower costs. The United States, as I said, over the last 5 to 10 years, we have digitized the record. We've not yet fully connected the parts. We partly have, but certainly haven't fully done it. We've done almost no gleaning of meaningful insights from the data, and that's partly what makes doctors so unhappy. They know they're spending a huge amount of time putting data into the system, and they're not getting very much useful intelligence out of it, and we've done very little converting those insights into actions that improve value. Now, I think it's inconceivable that a decade from now, all 4 boxes won't be checked. But I think it's really important to understand how very early we are in this process and how complicated it is to do all these things. So part of the reason I'm hopeful is I've come to recognize how early we are in a complex set of transitions. Second reason I'm more hopeful is in reading the work of MIT professor Eric Brynjolfsson. So Eric wrote about the experience of industries that adopted information technology. And when he did that, he coined the term the productivity paradox of information technology. What he meant by that is the paradox, meaning something that's confusing. The paradox of information technology was that here were these new systems, computer systems. Everyone said once they enter this field, they will make everybody more productive. They'll enter the factories, they'll enter Wall Street, they'll enter retail businesses, and they'll make everybody more productive. We know they will because they move data around faster and we can analyze things in different and better ways. The paradox is, and of course that was the hype, meaning that's how they were sold. That's why people spent the money to buy them, on this promise that they're going to make the business much more productive. The paradox is the technology came in and a year went by, 3 years went by, 5 years went by, and they were not seeing these promised productivity gains. So that was the paradox. It was captured beautifully by this Nobel Prize-winning economist now a long time ago, who said you can see the computer age everywhere except in the productivity statistics. We see computers all over the business, the factory floor, the retail business, and yet we're not seeing the productivity advantages that were promised. Now, again, the reason I'm hopeful is Brynjolfsson in ongoing studies demonstrated that the productivity paradox goes away. It gets better. You begin to see the productivity gains, but they often take a decade. They take 10 years. In healthcare, I'm guessing they'll take 15 years because it's so much more complex. because it's highly regulated, because some of it is taking risks. And in a business, if you take a risk and you fail, you might lose money. In healthcare, if you take a risk and you fail, someone might die. We've got to be a little more careful. But the message is the productivity paradox eventually resolves. And the lesson from Brynjolfsson's research and others like it are that there are two keys to making the productivity paradox go away, meaning seeing the benefits of the computers. One is obvious, the second is less obvious but more important. The obvious one is that the technology needs to get better. And if you're using electronic health records any bit like the ones that we use, maybe you're using ones that were developed in the US, like Epic or Cerner or Allscripts or eClinicalWorks or Athena, if you're using any of them, you know the technology needs to get better. The technology for medical electronic health records is nowhere near as good as the technology we're used to for our banking or for our travel arrangements or for doing web searches on the web. That's the first thing, obvious and not as important as the second. The second is what Brynjolfsson called reimagining the work. And the main reason this takes 10 years or 15 years is that in the beginning, what we do as humans is we put in computers and all we do is replicate the way we used to do the work on paper. So if the doctor's note used to be a piece of paper with a tab, and there was a section called doctor's notes, and there was another tab with a section called nursing notes, when we computerized it, that's exactly what it looked like. It was now a digital piece of paper, but the process looked exactly the same. Reimagining the work is someone comes in and says, why do we do it this way? Can't we come up with a new way of doing this thing that isn't stuck on the way we used to do it? Haven't you ever seen Wikipedia where the notes are created collaboratively by different people? Haven't you ever seen a Twitter feed or a Facebook wall and the communication is not only words but pictures and audio? All of that, that's what's meant by reimagining the work. And part of the reason it takes 10 or 15 years is you need the old folks to start going away. And the new folks come in and say, this makes no sense. Why are we doing it this way? And that's when you begin to see the real innovation. So that's one of the reasons I'm actually very hopeful. I'm beginning to see evidence that that is happening. So let me move toward the end and tell you why I think we're entering a new phase. Part of it is that in America, at least, when it came time for all of us to buy electronic health records, we bought them from companies like Epic and Cerner that were built specifically for to build an electronic health record. Companies like Google tried to get into healthcare a decade ago and failed. Turned out you needed to know a lot about healthcare to build an electronic health record. But these companies are not experts in building wonderful user interfaces like Apple is or Facebook is or Google is. They're not experts in learning from data or in artificial intelligence or in communication or in data visualization. What we're seeing now is as the architecture begins to get opened up and there's an opportunity for new companies to come in and not build the electronic health record, but take the data in the EHR and begin using it in new ways, we're beginning to see a lot of interest and a lot of money coming from Microsoft and IBM and Google and Apple and Amazon and others, all of them entering healthcare just in the last 2 or 3 years. And why now? Because now the data are digital. They couldn't have done anything 5 years ago when the data were on pieces of paper. Now that the data are digital, they see their opportunity. And we're beginning to see some amazing examples of innovation in artificial intelligence, digital scribes, all those sorts of things. And we're starting to see, just as importantly, not just new technologies, but examples of reimagining the work. So I want to give one example from my organization that points out the kind of thing that I think we need to see if we're going to take full advantage of our computer system. So I call it scaling the knowledge of specialists using digital tools. In the old days, if you were a generalist, either a hospitalist or a GP, primary care doctor, you did the best you could taking care of your patients, and you would call a specialist, an infectious disease specialist or a rheumatologist or a cardiologist, if you really, really needed their insight. But it turns out to be a pretty big deal in a hospital to call a specialist. They have to come in, examine the patient, read the chart, and probably take some 45 minutes or an hour. In the outpatient setting, the patient has to go for a separate visit and go to see them, and then they do everything, and then they write a note, and you might see the patient again weeks later. So if your only two options are, I do it myself as a generalist and do the best I can, or I call a full-blown consult, either inpatient or outpatient, what happens is you develop what I call an underground economy in curbside consults, meaning you spend a lot of time running into your colleagues in the cafeteria and say, you know, what do you think of this case? And they never see the patient, and they do. Sometimes they'll help you. Everybody's scared of getting sued in the United States doing that. But of course, curbside consults are a logical solution to this problem of you want specialty expertise, but you don't quite need a full consult. Now, we've been thinking a lot about this over the years, and one of the things we built starting about 7 or 8 years ago was electronic consults. So now at UCSF, about 20% of our outpatient consultations are not sending the patient to go see the cardiologist or to go see the liver specialist. It is what's known as electronic consult, meaning I write a note to the cardiologist and tell the cardiologist briefly what the patient's issue is. The cardiologist goes into the patient's electronic record, looks things up, and sends me back a note advising me what to do. And it turns out in about 1 out of 5 cases, that means I don't need to have the patient actually see the doctor. And we've figured out how to do this. The hard parts of it were not technical, setting up the system within our Epic computer. It was more, how are we going to pay the cardiologist? We actually pay the primary care doctor a little bit when they do this, because otherwise it's easier for them to just send the patient to get a consult. But we all felt like it's better for the patient and better for our system and more efficient if 20% of the consults happen this way. So we pay actually both parties, the specialist and the generalist. None of this came out of the box when we ordered our Epic system for $200 million. We had to build this, but the technical piece of the build was not the hard part. It was the workflow and the payment kind of thing. So let me take it to the next step and something we've done in the last year that I'm very excited about. So this relates to how we manage patients with diabetes in the hospital. And if you think about, we have a 700-bed hospital. Every day in our hospital, there must be over 100 patients who have diabetes. Most of them have type 2 diabetes. They're not that sick. But some of them have type 1, or their sugars are way up and way down. And yet, how often do we call a diabetes consult, an endocrine consult, to help us manage them? The answer is almost never. It would really be very rare that we would say, this patient's diabetes is so horrible that I really need the specialist to come and help me. And yet there are probably a lot of patients where if the specialist was looking over my shoulder, he or she could advise me and I would do a better job managing the patient's diabetes. So that's the nature of the problem. So this is the way we have reimagined the work. At 6 o'clock in the morning every day, sitting in his house, our diabetes specialist, whose name is Rob Rushikoff, reviews the data for every patient in our hospital who has diabetes and meets one of these 4 criteria. Either type 1, they're on an insulin pump, their sugars are 2 of their sugars are very high, or 1 of their sugar is very low. We have built into our Epic system a triage that looks at every patient in the hospital, and any patient who the computer says meets one of these 4 criteria, Rob Rushikoff gets them stacked up in the morning in a computerized queue, and he then looks at them. And that's him on his computer screen in the morning. Now here's the computer screen that he sees. We had to build this for him. This also doesn't come out of the box from the Epic system, but probably took a day of work by one of our programmers. It's not that hard. And what you see is what he sees, which is the patient's sugar trend over the last few days, all of their diabetes medicines, both pills and insulin doses, their relevant laboratory studies, other medicines they might be on that might influence their sugar, including their IV drips and whether they're on a steroid. For all of those patients that were selected because they met one of those 4 criteria, he gets a screen like this. And so he looks through about 20 of these screens, And he tells me that in about half of them, when he looks at what the doctors are doing, he thinks it's wrong. He thinks that the insulin dose is not right, or the diet's not right, and he believes there are some recommendations that might help the care. What does he do? He fills out a consult note without ever having seen the patient, and it comes from what's called the glucose management service. So if you're a doctor in the hospital, you come to your chart in the morning and you might say, oh, here's the cardiology consult I called, and here's the infectious disease consult I called, and here's this other consult from the diabetes management service. I never called them. How did that get there? And in fact, our residents now have turned this into a verb. Our residents say, I got Rushikoff. That's how they refer to this when a note from Dr. Rushikoff shows up in their chart. Well, how does this work? Here's a study that we published in the Annals of Internal Medicine last year. And it turns out that the proportion of patients with low blood sugars was 36% lower, and the proportion of patients with high blood sugars was 39% lower in our first year of doing this. I asked Rob how long it takes him every day to run through that entire list, look at those 20 patients, write his notes on the 10 sickest patients. Takes him about an hour, meaning in the time that it used to take him to do one consult, he now basically screens the entire hospital diabetic population for the ones that are particularly sick, then screens those to see whether we're managing them correctly, and when we're not, he gives us advice, and the advice leads to better outcomes, lower sugars, less hypoglycemia, less hyperglycemia. You might think, how do the doctors accept this, getting this advice? Are they unhappy about it? It turns out in another study that the proportion of physicians who said that they learned something and thought this was really good for patients was incredibly high. So people believe this is helping their patients, it helps them manage patients. And to me, this is a wonderful example of reimagining the work. We couldn't have done this without the computer system, but it wasn't the computer system that did this. It was just taking a look at what we were trying to do and using technology in a new way to accomplish an important goal. Well, let me end with this. This is a story I like to tell that I think it sort of makes clear where we are in healthcare. This is the Choluteca River in Honduras. And it's a part of Honduras that gets lots of hurricanes and terrible weather. And about 30 years ago, they had to rebuild the Choluteca Bridge over the river. And so because of all the hurricanes, they called one of the world's leading bridge design firms in Japan of all the hurricanes, so they built the Choluteca Bridge. And as they feared, along came, a few years after the bridge went up, along came a hurricane, Hurricane Mitch, blew down thousands of houses, terrible damage, but the bridge was built in a very, very strong bridge, and it withstood the hurricane, and there was barely any damage to the bridge at all. There was only one little problem, and that was that the river moved. And to me, this is a wonderful metaphor for healthcare, at least in the United States. The river is value. The river is how do we figure out how to deliver care that is better, safer, more satisfying, more accessible, less expensive. And we need to build a new bridge. And I'm quite sure the bridge will have digital in it. It won't be all digital, but it has to be digital. And the two keys, or at least I've mentioned, are reimagining the work, and I've given you two examples of ways of thinking about innovation and the work in different ways. One is a non-digital example, which is hospitalists, but the second, and the one I hope has been helpful to you, is this idea of once we digitize, thinking about the work in a new way, and how do we use digital tools to improve value. And I'm now quite optimistic that we're going to get there, but it's not in the first couple of years after you put in your computer system. It takes some time and it takes some energy and takes the culture where people think about their work in a new way. So with that, let me end, and I've enjoyed talking to you and look forward to hearing any comments or questions. And I will stop sharing my screen.